So they have, actually they are very, very common. The herpes viridae or the viruses are very common. There are 130 viruses or more. Only 9 infects humans and only 8 are clinically significant. I will tell you in the next slide. Okay, so they are classified according to the subfamily alpha, beta, and gamma. And the classification is based on genome structure, tissue tropism, cytopathologic effect, site of latency, pathogenesis, and disease manifestation. Okay. So this is how almost all the virus invade a host cell. Okay, so let's take for an example the herpes viridae. So you have here your herpes virus. You call this your leader. Okay, imagine this as your leader. So the herpes virus attaches to the host cell. Okay, so this is your herpes virus. This is the host cell. The envelope opens up and then it releases the nucleocapsid. Okay, it travels through the cytoplasm and then the nucleocapsid attaches to the nucleus of the host and then the nucleocapsid opens up and it releases the viral DNA. It is inside the nucleus. You see here, nucleus. Okay, it is inside the nucleus wherein the replication takes place. Okay, so you can see here new viral DNA, okay, and then the mRNA, and then the early proteins. Okay, the early proteins are the ones that produces the new envelope. Okay, and you call this your reinforcement. Okay, because without the reinforcement, the virus will never have an envelope and it cannot travel into the host, outside the host cell. And you can see here late proteins. These are your builders. Okay, the late proteins are the ones responsible for making up the capsid that will enclose the new viral DNA. So once it is enclosed in the capsid, the early proteins will then envelope it, and part of the envelope of the new virus is a part of the host cell. Okay, so when it travels from the nucleus to the cytoplasm to the outside of the host cell, it takes up a portion of the host cell envelope. Okay, so that's how all your viruses invades host cell, almost all. Okay, including HIV. All this is how they replicate. However, the RNA virus or the HIV, instead of replicating in the nucleus, it replicates in the cytoplasm because it's an RNA virus. Okay, so these are your subfamily, alpha, beta, and gamma. Okay, so we mentioned that it is classified according to the site of latency. The alpha family, they are latent in the neurons. The gamma in the lymphoid tissue, and the beta in the salivary gland mix. It's a mix, okay? So these 130 herpes viruses, but only 8 are clinically significant, okay? And everyone here is important, okay? Everyone here, you need to know. So HSV1, this is the common name, and official name, you should know the official name. Human herpes virus 1, okay? HHV, okay? HSV2 is human herpes virus 2. Varicella zoster virus is your human herpes virus 3. CMV, your HHV5, 6 and 7, okay, I'll spare you with this. This is not very, very important. Why? Because the HHV6 is the one that causes your Rosola infantum or your 6th disease. This is important with pediatricians. This has no gynecological significance. And pityriasis rosacea, this is important with your dermatologist. Okay, so you can skip memorizing the 2. Okay, and then so you have here 1, 2, 3, 4, and then go back 5, and then 8. Okay, so your Kaposi sarcoma herpes virus or your HHV8, okay, this one previously came out in the exam. So please don't forget, okay, this is an outright exam question. This is a recall question. Why? Because a lot of people were thinking that Kaposi sarcoma virus is related to HIV, which is correct, right? So if you have an HIV, you are at risk of having Kaposi sarcoma. So people were thinking, and the students were thinking that the one that causes your Kaposi sarcoma is that the HIV virus. No. The one that causes Kaposi sarcoma virus or your KSHV is your HHV8, okay? HHV8. Okay, so this is and also remember that the one that belongs in your gamma subfamily are the one that causes your malignancy. So EBV and Kaposi sarcoma herpes virus are the one that causes your malignancies. So you can see here, you have your nasopharyngeal CA, Hodgkin lymphoma, okay, post-transplant lymphoproliferative disorder, Burkitt's lymphoma, infectious mononucleosis. Okay? So let's go first with herpes simplex virus 1 and 2. So this is the one that causes your HSV. So these are the significant viruses, HSV 1, 2, 3, EBV, and 5. And remember the 8 for your Kaposi sarcoma. Okay? So HSV1, we all know that HSV1 are the one that causes your oral herpes. And HSV2 is the one that causes your genital herpes. Okay, so this one is the oral and your genital. Okay, so we know that, right? So HSV1, anything above the waist, and HSV2, below the waist. Your HSV1 also causes the herpetic whitlow and herpes gladiatorum. When you say herpetic whitlow, these are the herpes virus or the herpes simplex viruses that affects the digits of the hands or the feet. And herpes gladiatorum are the one that causes herpes infection. These herpes gladiatorum are common among people who engage in contact sports or boxing or wrestling. Okay? So before, you see this diagram? Okay. HSV2 or your genital herpes, 30% of it was caused by your HSV1. And 70% of it was caused by HSV2. So that means both HSV1 and HSV2 causes genital herpes. And this is the proportion. That was before. Okay, now, so please note of this. Now, HSV1 causes, this is now the most common cause of your genital herpes in the UK. So when you encounter in the exam, what is the most common cause of genital herpes in the UK? It is not HSV2, okay? It is HSV1. So remember, HSV2 is only a history now. Historically, it is the most common cause of anogenital herpes in the UK, okay? But now it is replaced by HSV1, okay? So this is how you diagnose your HSV. Clinically, when you see a lesion, okay, by swabs, by vital culture, which is the gold standard, and your nucleic acid amplification test, okay? So unfortunately, there's no treatment for genital herpes. Once you have it for life. So it goes only latent in the neurons. Okay, and it gets reactivated once you become immunocompromised again. So the only treatment is for symptomatic relief, analgesia, bathing, topical anesthetic. And the antiviral regimen for herpes simplex virus is your acyclovir. Okay, acyclovir 435. Why is it 435? 400 milligrams, 3 times a day for 5 days. Okay, and valacyclovir is an alternative. Okay, so it's 400 milligram 3 times a day for 5 days. This is for your herpes. You have to remember this because the treatment for your varicella is also acyclovir. Okay, and I will tell you the code for varicella later on. So the treatment should be started within 5 days of infection while lesions are still forming. So within 5 days while lesions are still forming. Incubation period, we have difference from different sources. The incubation period is 2 to 7 days. Okay. Any questions so far before I go to the algorithm? If you have questions, you can reserve it later on. Just write it and we will answer all questions later on. Okay. So this is very, very important. Okay. I want to have your 100% attention in this algorithm. Okay. So this is the management of herpes in pregnancy, and this came from BASH guidelines, if you want to read more about it. Okay. So in herpes and in varicella, what is important is the management, because in part 1 exam, they are fond of giving scenarios about herpes and scenarios about chickenpox. Okay. So for herpes, you have to determine whether it is the first time that your patient had a herpes or whether she has a history of previous infection. Okay, so when she has a history of previous infection, she came to your clinic and she says that I had the same lesions, same kind of lesions, exactly the same kind of lesions before, like 1 year ago, or 2 years ago, or 6 months ago. If she claimed that, then maybe she falls under recurrent genital herpes. Okay, so this is your first scenario. For recurrent genital herpes, you treat episodes with standard doses of acyclovir. What do you mean standard doses of acyclovir? It is your 435, okay? 400 milligrams 3 times a day for 5 days, okay? So, second scenario, primary acquisition of genital herpes in the first or second trimester. So, recurrent genital herpes in any trimester. Primary in the first and the second trimester, okay, the same. You will also treat with standard doses of acyclovir, okay? 400 milligram 3 times a day, and then you stop. So this one, that means treatment upon diagnosis, and then you stop, and then you treat her again at 36 weeks age of gestation. This is what you call suppressive therapy or treatment. Okay? So the difference is, in the third scenario, okay, you got the patient in the third trimester. So everyone knows what is the start of the third trimester, right? So what is the start of third trimester? How many weeks age of gestation? Anyone? Guys, wake up, wakey. What is the start of the third trimester?
28 weeks.
Okay, thank you. So, 28 weeks. So I'm just testing if you're still with me, because microbiology is a very boring subject and we conduct it at a very boring time. Okay, so please, if I ask question, reply right away, because I will not proceed if you don't answer me. Okay, so beginning at 28 weeks, when the patient got primary herpes, use the same, you will treat with standard doses of acyclovir, but there's no stopping. That means you continue treatment until delivery. Okay, no stopping. So that's the main difference between scenario 1 and 2. Upon diagnosis, you treat, and then you stop, and then resume treatment at 36 weeks until delivery. While in the third trimester, you treat upon diagnosis and no stopping, continue until delivery. Okay? Especially if it is within 6 weeks of delivery. Okay? Here, you can see here, consider acyclovir until delivery. No stopping. Okay? And then you recommend cesarean section, especially if the patient got herpes within 6 weeks of delivery. That means that is 34 weeks. You have to be very, very specific with the timing. Okay? So if it is within 34 weeks, it should be a recommended planned cesarean section. For the primary and the recurrent, primary in the first and second trimester, you can offer the patient vaginal delivery. Okay? The fourth scenario, if you see a patient with genital herpes lesions at delivery, okay, in other colleges like the RCPI, okay, the RCPI. So in the RCPI, if there's active genital lesions at delivery, they offer cesarean section. But for RCOG, okay, for RCOG, you are taking RCOG exam. If you see genital herpes lesions at delivery and it is in the first and recurrent, okay, you can deliver by normal spontaneous vaginal delivery. Okay? Okay. So for example, you get a patient in the third trimester, okay? So you advise her to have cesarean section because it is within 6 weeks before delivery. She insisted, okay? She insisted on having vaginal delivery. It's okay, but you have to ensure or you have to inform her the risk and you inform the neonatologist, okay? Inform the neonatologist and then you will give the patient a different dose of acyclovir. The baby, okay? You'll give 20 milligrams per kilogram and the mother, you will give 8 milligrams. I will show you in my next slide. So you can see here, if a patient insists of vaginal delivery, this is my own nose, so pardon it, it's very, very small. Okay, so insist, let me see, okay, I can, so it's now zoomed out. Okay, so if a patient insists of vaginal delivery or conservative management, you have to give the mother acyclovir 5 milligrams per kilogram every 8 hours. Okay, and then you give the neonate upon delivery 20 milligrams, and then inform your neonatologist. Okay. Any questions regarding this?
Yes, ma'am, I have a question.
Yes, dear.
Ma'am, in the fourth scenario where you told that if the lesion is seen at the time of delivery, so is it that we were following the patient from initially like in the first trimester and then we gave her acyclovir and then we started the acyclovir again at 36 weeks, but then the patient is showing the lesions at the time of delivery? Is it that scenario or is it like we are seeing a completely new patient at the time of delivery and we see that she has genital lesions and then we do what followed next?
No, this is under recurrent and primary, you see.
Yes. So
Jenny,
that is the
that
patient
means,
is treatment, but she still has the lesions, is it?
yes. And,
Alright.
but she can undergo normal delivery because it's a recurrent and
She has
you
already
got
taken.
the patient get it either. Yes, she has
Yeah.
already taken a cyclovir.
Thank you, ma'am. Thank you.
Welcome. Okay, so guys.